Okay, let me see who is here. Okay, now Dr. Mana is here. Let me ask her to join us.
Hello.
Hello, how are you?
Good. Thank you. How about you?
Thanks. Happy to have you here.
Thank you so much.
Welcome
Thank
to the
you.
show.
Thank you. Thank you so much. Thank you for inviting me. Let's wait for others.
Thanks for accepting our invitation. Yeah, I'm waiting for Dr. Ahmad and Dr. Parisa.
Yeah.
Let's see if they have joined us or not.
I think not yet.
No, not yet. If my friend Ehsan is in the show, I ask him to text Dr.
Yes, let them.
Parisa and Dr. Ahmad to join us. We are waiting for them. Do you have my voice clearly? Can you
Yes,
hear me?
I do. Yes, I do. That's perfect.
Okay,
And I
good.
like your background. The background is really nice.
Yeah, the background is Endo
Yeah.
Leader Show.
Yeah. Yeah. Hello, Dr. Rahimi.
Yeah, Dr.
Rahim.
Fariduni, one of
Yeah,
the greatest
I
endodontists
had difficulty.
in the
Yeah.
Iran is here. Happy to have you here, Rahim. Welcome to our
Yes.
show. It's an honor and it's a pleasure to have you in the show. Happy to have you here. Okay. Dr. Ahmad texted me before the show, but I don't know if he could join us or not. We will wait if it takes a long
You
time.
want me to text them? But
Yeah,
I
please
think,
text them.
well,
And
yes.
I prefer to end this show and start a show again because we want to save the show, and it's good to start it completely with a good beginning.
Okay. So, okay. Yeah. Okay. We'll come. Oh, Dr. Parisa is joining now.
Dr. Parisa.
She's here. Yeah, she's here.
Yeah, we have both. Dr.
Okay, good.
Ahmad is here. Okay, no problem. I will ask them to join.
That's perfect.
I cannot see.
Hello.
Yeah. I found Dr. Parisa too.
Hello, Dr. Ahmad.
Hello, Dr. Mana. How are you doing?
I'm good. Thank you. Hope you're doing well.
Yes, everything is going well.
Very
Hi, Dr.
good.
Parisa.
Everyone is here now. Hello, Dr. Parisa. Hello, Dr. Ahmad. How are you?
Fine.
Can I ask you, Dr. Parisa? I don't have her.
But I have.
You don't have me?
Parisa.
I have only her voice. I can't see her.
Really?
I can see Dr. Ahmad only and you. Yeah.
Okay. Parisa,
I
can
can't see
you
Dr. Parisa.
But dear Dr. Muna, I
disconnect
can see all of
from
you.
the show and rejoin the show?
Do you want me to end the show and rejoin?
Just Dr. Parisa. I think
Okay.
it will fix the problem.
Okay.
Okay, outside and come back because I can see
Yeah,
everyone.
please go outside, and then I come to the show,
Okay, I'll go.
live, and I will ask you to join again.
I will leave it right now.
Okay.
Okay, thank you. How was your day? How was your endo day? Did you work today?
Yeah, it was very nice. I had like 6 cases today, and everything went well. So thank God, everything is okay.
Very good. It was a tough endo day, or it was an easy endo day?
No,
Because
it
I
was.
think as an endodontist, we don't have any easy day.
Yeah, we can say it's an easy day. It's not the hardest, but it's fine.
It's
Yeah.
very smooth. Yeah.
Yeah, it's very smooth.
Okay. Let me see if Dr. Parisa has joined us again or not. Dr. Parisa is here. Let me. Dr. Parisa, don't ask us to join. Please let me ask to join. Okay. Dr. Mona, do you have Dr. Parisa with
No,
you or not?
no, I don't.
Not yet?
Not
Now
yet.
I don't see. Oh, okay. I see all of you.
I don't
I can see
have
Dr.
Dr. Parisa.
Guys,
Oh, it's weird.
I'm okay. I see all
Dr.
of you.
Parisa, did
So
you send me did you send me a request to join the show or not?
Yes, I sent you.
Please don't send me the request. Disconnect from the live, then reconnect again. Let me send you the request, and you accept my request
Okay,
to
I'll
join.
go.
Yeah. Telegram,
maybe
Instagram is very weird.
maybe the problem would be on my side. Do you want me to go out and?
I can see
check
Dr.
this, and
Barisa.
then I will end this.
I can see Dr. Barisa both times, so I think maybe Dr. Mona have a problem.
Yeah, it's maybe the Dr. Mona's problem.
Okay, if it didn't work, I'll try it. Yeah.
Yeah.
If it didn't work, I'll try that.
Last try. Let's see what happens.
Hopefully, it will be okay. Okay.
I can see Dr. Barisa now.
What about you, Dr. Mono?
Okay, and Dr.
No,
Ali,
I
now
think I have to.
No problem.
you send me the
We can handle
request
that
and I
because
accepted it.
the save the video will have all of us together.
Yes, I can see Dr. Barisa, and all of you, everything is going okay.
Me as well.
Yeah.
I can see all of you.
So, do you want me to try again?
Yeah, you try again, Dr. Mono.
Okay.
But
Okay.
please wait for
Yes.
me. I will send you the
Okay, sure.
join request. Thank you. How was your day, Dr. Parisa? A tough day or an
It was
easy
good.
day, easy end of day?
It was an easy end of the day, you know. And I'm not a fan of sport, but really, you know, a lot of people love football. And now that Paris Police has won, everybody is happy. And you know, it's just good vibes that's all around me. I'm happy.
Okay.
So you had football today in Iran?
You know, right now there was a football match between Paris Police and Istiklal, and they were like fighting with each other. And
it's fine now. I can see you all. Hi.
Hi.
Hi, how are you? Hope you're doing well.
Oh.
Okay.
So happy to see you.
Yeah, me too.
Okay.
Okay.
We are all together now, and let's start the show officially. Thanks for accepting our invitation for this show. As you know, the title of this show is about bioceramic sealer. We want to see what we have now and what is the future direction of bioceramic sealer. Can we do any endodontic treatment with single cone technique with bioceramic sealer, or it is not indicated and it is not a good technique to be done in your daily practice. Okay, I ask Dr. Ahmad to start any introduction to the bioceramic sealer if he has for us, and we will continue with the others.
Okay, please let me flip my my camera. I can. How can I flip it? That's a problem.
Yeah.
Do you know how can I flip it? I would like to show you my.
Yeah. There is an arrow. There is a two-side arrow on your actually.
It's next to the
side.
camera.
Yeah, it's next to the camera icon.
I don't have it here. I can see.
Camera icon.
It's just below the window. So there's 4 options.
Okay. I only have add comment and send message. This is below, and I have the group we are joined to. That's a problem.
What about your window on your screen? Under your picture on your screen, there is also, I think, choices and icons that you can choose between them.
There's nothing appearing to me. Only to exit. Only and the mic.
Yeah, it should be next to the mic, I think.
Yes. Okay, let me try to exit and come back. Maybe it will fix the problem because I have no icons.
Okay, no problem. You can.
Okay, excuse me. I'll be right back.
Okay, no problem. This is a matter of Instagram. No problem. We will wait.
The difference between virtual world and real world, you know?
Yes. that's true.
We have the same issues actually at any congresses and any conferences and any webinars, but we will handle it, no problem. We should just be patient.
Hopefully.
And all the endodontists are patient. We are master in this skill.
But it's so good to feel next to each other because, like, Dr. Mona is in Dubai, we are in Iran, and all of us are separated, but now we are with each other. It's really good.
Now I'm back, and I have the option now. There was a problem with this. Okay.
Very good.
I'll just do like a short introduction to the bioceramic and how will it affect our practice in endodontics. First, what is the composition? It is a combination of different elements. Let's say it's all about a bioinductive or a bio-reactive material. The first one and the most popular one is calcium silicate and calcium phosphate. Some manufacturer would add calcium aluminate. Some others wouldn't prefer to put aluminate as it may be a potential toxic material. Zirconium have been put in the composition due to the radiopacity. It gives the radiopacity to the bioceramic sealer and also gives the durability. And during the setting, we have 2 additional material, calcium hydroxide and the bioactive glasses, which looks like hydroxyapatite. Lately, one of the manufacturer added the strontium silicate, which is named the C sealer or C bioceramic sealer, something like that. And all the composition we have are focused on regenerative and antibacterial effect. They give a regenerative and the antibacterial effect to the sealer, and also they don't shrink, they don't dilute or wash out by time. Bioceramic looks very promising to our practice. I have been using bioceramic for like 5 years, and I have great results with the bioceramic. So that's it about the composition. If you would like to ask my colleague about it, then we can go to more of the effects of the bioinductive, or would you like to go further with some more information?
Okay, you can go on with any information and data you have, and please, if you have any cases, share us, and then we will talk about the concept. We will talk about the techniques that use in our daily practice, and I will ask others to share their cases or anything or any content they have. No problem.
Sure. Now, what's different about bioceramic? What is the good thing we have, and we didn't have these properties with our previous sealers? Bioceramic have the most favorable thing we need, which is biocompatibility. Most of my cases, when I used to have resin sealer as my main sealer, suffered from severe postoperative pain to moderate postoperative pain. It depends on the point I end my preparation, if there is a periapical lesion that was filled by the sealer. When I started to use bioceramic, everything went well. So bioceramic usually doesn't have that effect, that doesn't have the toxic effect resin sealer had. So many of my cases, when I use bioceramic, they suffer from a minimal to none post-operative pain, which is very good for me. I would like to have all my cases pain-free during and after my visit. Also, it's bioactive. What does it mean bioactive? It goes during the product setting. We have a byproduct of calcium hydroxide and other products that would go beyond the apex and induct or start a new tissue formation. It would be angiogenesis and also osteogenesis procedure followed by the setting of bioceramic. It has an alkaline pH, which is the most favorable thing we would look for. When we have alkaline pH as a permanent sealer in the root canal, that means we have a long-standing antibacterial effect. Zero shrinkage, and this is the point from which we started to use the bioceramic as a single cone. Because the shrinkage problem, we had a percentage of shrinkage for resin sealers and also the getapercha. The getapercha shrinks if we used it as a warm vertical compaction technique. So no more gaps, no more spaces if we manage to put the bioceramic correctly to the root canal, if we manage to deliver it to the apex. Also, the flowability are superior. Resin sealer was viscous, was hydrophobic, wasn't able to go to everywhere in the canal, especially the lateral and accessory canals. Bioceramic is more superior in these properties due to the hydrophilic property and the high flowability. As I mentioned, less postoperative pain, faster bone regeneration, and better tissue repair. Here in this case, this is a case I did treat like 4 years ago, and the patient was suffering from a severe pain from a tooth that was treated 3 times before it came to my clinic, and she had a fistula in the buccal vestibule. After root canal disinfection and removing most of the old obturation material, we didn't manage to retrieve the part of the getapercha that was beyond the apex, but we did disinfect the root canal with the calcium hydroxide for like 3 weeks. Then I bought a bioceramic sealer, but here in this case with a called lateral compaction technique. Wasn't a single cone yet. I didn't go to the single cone 4 years ago. I just started to use single cone 2 years ago. So after 4 years follow-up, we can see the lesion is there is complete healing. The bone deposition was great. The patient has no signs or symptoms. Everything was going good for her. Maybe with resin, I wouldn't get the same result, or it maybe need a surgical interference. Many cases are treated non-surgically after I started to use bioceramic. Please let me show you one more case that I think it would be very nice. This case also, it was a referred case to my clinic with a broken file at the apex as a distal canal, some of remnant gatapertia at the apical third in the mesiobuccal canal, and a perforation that was made by a drill or a retreatment file in the mesiobuccal canal. Here in this place, it would be very hard for me to push MTA and make it goes to the place I need. So I started to retrieve the old obturation material. We couldn't get the broken file back. We did the root canal disinfection and obturated the case with bioceramic sealer. This part we have here that is going out mesially from the root. This is a bioceramic sealer. Here after 2 years and 3 years, we have a great healing. If you can notice, the bioceramic have been treated as a part of the root. The periodontal space, I think, is adapted to the new shape of the obturation material. So it didn't wash away. It wasn't soluble. It didn't wash away. The patient had no signs or symptoms. Everything was going good for him and no pain. So I tend to believe if the bioceramic was used correctly and placed in a good technique, that will help in healing and also will help in regenerative effect. I have many cases, but I would like to give the chance to my colleague to share their cases, and if we have time, I can share more cases with a new bioceramic I just used lately, which is en-route. I will put en-route at the end, but now these cases was made by BioC from Angeles. This is a very nice bioceramic sealer. I used to treat my cases with BioC for like 3 years. 1 year ago, I started en-route, and it gives comparable results. We will see other cases. Thank you.
Thank you. Thanks for your great presentation.
Thank you,
and your
Dr. Ahmed.
informative information. Very good. I have some questions about the bioceramic sealer, but I will ask it at the end of the actual cases that we share. I will ask Dr. Paisa if you have any case and you want to share it with us.
Yes, I have about, I think, 2 cases that I would like to share with you. And, you know, I like the subject of noticing that really, is it a myth or a paradigm shift? You know, the subject is very innovating, and I think we should think about it. What's happening around us? You know, in the traditional obturation, we always thought that the canal should be obturated with gutta percha, and the sealer is like going around the gutta percha just to fill the gaps. But nowadays, it's really, I think it's really interesting that all of this has changed. And nowadays, we are seeing that the thing that is important, maybe it's a sealer. Why? Really, why? Why are we changing everything? I think the main subject is that we want to have an easy life, very easy, you know. It's simple. It's simple. I like to do Muller in like 20 minutes, not 1 hour and a half. Okay, in the lateral obturation, lateral condensation, I put it the MAC and then another gutta percha, I condensated it. But you know, when we have these kinds of concepts like, okay, just a single cone, and let's fill the canal with sealer, it makes our life easy. And having an easy life is, I think, beyond the things that we want. And I really like the changing of philosophy of root canal obturation. And this is, I think, the main point, that we are sharing our cases with each other to know that, okay, everything is changing. Like maybe when I was a baby, I just crawl on my on my hands and legs, but now I'm walking, and maybe we will walk faster. Okay, when we have the simple technique, we use just a single cone. We use bioactive sealers that are so biocompatible. It's really great. And when I have a case and I'm thinking that I want to have a rapid healing, I want to change the pH, you know, I want a very good environment around the root canal, well, I want to choose these kinds of sealers.
Exactly.
Like I have cases that I've used, like some brands of sealers, and I will share with you. Like the first case that I want to share is this case is it's a kind of premolar. I've shared it in my Instagram page. As you can see, this is my obturation and final radiograph.
Can you move your camera closer to the actual cases?
I can zoom it. Yes, I can zoom it.
Thank you.
You know what's happening over here is that when I obturated this canal, yes, I have sealer puff. You see, but
we can see the premolar. Can you change
yes,
the view?
Yes, it's here. Look, this one.
A bit righter, please. Please, a bit righter. Right, or right. If it is possible, change the direction of your camera. I think it will. Yeah,
yes.
Exactly. Thank you. It's now better.
And then, after only a little time, you see what's the difference. I want you to see, and we can see the difference between these two radiographs just in 1 month. It's such a wow. Okay, do we want or expect that this happens always? No. Like we know, sometimes we have the sealer and it will be over there, but it's not such a factor in our success because we know it's biocompatible, but we are seeing the healing process. Or I want to share another case, like I've shared this one in my Instagram page, because the follow-ups are really not in a very long period, but I want to share them just you to watch. And I want to say that sometimes that when we have a patient that doesn't have any symptoms, I think it's a good thing. And I've followed this patient about 2 months later, and I mean, he has a good condition beyond of everything. And you can see the like anatomical things that are around the root, like the inferior alveolar canal. And now I want to share this case. I followed it just in 2 months, and we can see the, you know, lesion is getting smaller. Maybe we can recommend some CT scans as well. And another case that was really for me special, and I was working on it recently, like this second molar. As you can see, like we had a missed canal, and the anatomy was C-shaped. You know, the fact that I'm saying there's a difference between the initial radiograph and what's happening after. Okay, what I use the bioceramic sealer for obturating this canal, and all of the symptoms of my patient was completely resolved. And I like to be an easygoing person. And when I just injected this sealer into the canal, I really loved it. You know, when I put it in the distal canal and I noticed that it's, you know, spreading in the entire canal, and I saw that beautiful C-shaped anatomy, it was really beautiful for me. And after all, sometimes, you know, the result matters. It's really different. You know, this is such a kind of case that we say, okay, the before and after is different. And I just share these cases to show that, okay, I wanna do something simple, easygoing, in a, you know, in a not that much time, and have good results, satisfied results. And I think in a patient, when we don't have pain or we see a rapid healing, it matters. And you know, in the past, like 10 or 15 years ago, when single cone operation with bioceramic was like introduced, and a lot of endodontists in that time were trying to use these kinds of concepts. It was new and it was different, because we always thought that gutta percha is the main material. But nowadays we know that it's not that important. Irrigating, cleaning, flaring, shaping the canal, and after all of this, using a very good sealer so we can have a good spreading, and in the entire canal will be with that sealer. And after, like, just one cone in it, and we can cut it, and you know, finito. It's really good. And always I think the results matters. And another thing that I think it's really important in these kinds of sealer is to know that how we should use them, how you know, I mean, in bioceramic sealers, we should be a little bit conscious about the anatomical things that are around the root. Mm-hmm. And you know, I have some things in my mind that we can use so we can be aware, or we can be conscious about the anatomical structures are around. But I really want to know that, like Dr. Mona, Dr. Ahmad, or you, Dr. Ali, what do you prefer, or how can you you know, I want to know what's your concept to be aware about the anatomical structures, and how can we stop the sealer to spread around, you know?
Very good question. This question is one of my questions that I was I meant to ask you. Okay, well, I think the time is good to ask some question about the bioceramic sealer, and let's discuss our concepts and our beliefs about this technique. The first question, I think it should be Paris's question, which is very important. Actually, my technique to be cautious about the anatomical structure, for example, a failure alveolar nerve, or for example, the sinus at the maxilla is very important to be considered. In these cases, the technique of actually injecting the bioceramics into the root canal system is very important. In such cases, I prefer to just inject the bioceramic sealer only on the actually 1/3 of the coronal part of the root canal system. And I prefer to just inject the bioceramic sealer at the coronal area. And if I have an open apex actually teeth, or if I think there will be a high amount of apical extrusion of sealer, I will go for other techniques. I prefer to use a sealer that is not flowable, because the bioceramic sealers are very flowable, and there is a very characteristic feature of the bioceramic sealer are thixotropic feature. It means that when you put pressure on the bioceramic sealer, it will flow better. It's not flowable, but when you put the pressure on the material, it will have a high flow. So if we want to be avoided about the extrusion of sealer, we have two options. We should inject the minimum amount of the bioceramic sealer at the root canal system, and also we may need to change to other actual sealers that we have in the market. For example, we should change to a resin-based sealer because they are not as flowable as bioceramic sealer. This is my concept, and actually I choose between one of these techniques. Okay, Dr. Mona, please tell us your technique, and then we will go to Ahmed.
Actually, first of all, thank you, Dr. Ahmed and Dr. Parisa, for your cases. And I do the same thing. Usually, I choose my sealer based on cases that I have, the same as you, Dr. Ali. I use resin-based, epoxy resin-based, which is AH+, and I use bioceramic cases. The thing is that in cases that I think in lower 7, which is close to anatomical nerves, I'm not using bioceramics most of the times. I try, because I like warm vertical, to be honest. I use resin-based. So I use AH+ and I use warm vertical. If I want to use warm vertical technique, I will not use bioceramics. I prefer bioceramics with single cone, because I think we need to know why we are using bioceramic. Like if we are using bioceramics, it's kind of a single cone is like a sealer-based technique. So we need bulk of bioceramics. But in warm vertical, it's there will be mass of gutta perca in the canal. So this is one of the things that I really pay attention on it. In single cone technique, I will use bioceramic, but if I want to go with warm vertical, I will use AH+. The other thing, I think that heat has, many studies shows that the heat will change the properties of bioceramic sealers. Actually, we can some companies tailored the composition of bioceramic sealers to withstand the heat stress. But it showed that it changed the flowability, setting times, or even antimicrobial properties of the bioceramic sealers. That's why I prefer the single cone with bioceramics. And I want to ask Dr. Ahmed about the cases that you showed us. Is it single cone or warm vertical? Are you using single cone with bioceramics?
No, with bioceramic, yes. Lately, I have been using single cone, but before I wasn't 100% convinced with the single cone. So I used to do lateral compaction even with the bioceramic. When the root canal is larger or very wide, it wouldn't be enough to just put a single cone, which is taper 4 or taper 6. I would like to add auxiliary cones. To make the majority of the film material is gutta percha, not bioceramic, and to push the bioceramic to the margins, to the walls, to the lateral canals. Later on, when I have irregular canals, when I have small canals that I am pretty sure that the master cone would be fit, there would be no spaces between the cone and the canal. I use a single cone in these cases. But what if I'm treating an upper molar with 2 or 3 buccal canals, which are regular size, and the palatal one is very large? I would make it as a single cone buccally, but when I go to the palatal canal, I would add auxiliary cones. I still prefer warm vertical the same as you, but when I do warm vertical, I use a different resin sealer, which has a 14% MTA في الأبيكس from Angeles. It's a combination between the bioinductive effect and the properties of the resin and the flowability, the viscosity of the resin sealer, and still it is heat stable. It is not affected by the heat as bioceramic. Bioceramic is easily distorted by heat. So I'm doing a combination between both, but I can say even my resin sealer is still a bioactive sealer because it has the part of MTA which gives the bioinductive effect.
Yes, that's true. That's true. Yeah, because the heat will affect the properties of sealer, but some companies and some brands they have a newer version of the sealers that they altered the composition.
Yes, exactly.
Exactly. I wanted to say that because you know, the other name of single cone obturation is hydraulic condensation, you know. And
Exactly.
it means that the sealer is condensing and there is no need of a spreader or any pressure. And the sealer is producing that kind of pressure that needs to seal the canal. And nowadays, a lot of companies, you know, claim that they really don't affect, and I mean that the sealer doesn't affect heat, and the heat doesn't have effect on flowability, setting time. I know, you know, we have a lot of articles that said that heat may produce like a film thickness, or it will affect the setting time or the viscosity, and it's not good. I really agree with this. But nowadays everything is you know, changing, and we have like bioceramic sealers that we can use, and even we can use heat with them. But okay, I agree that maybe just a small cutting with a single cone technique, if the canal is like not oval, you know, the canal should be like a circle in the axial axis. Okay, in that case, we can use one
I have prepared like
Dr. Ahmad, because
yes,
in the canal that are oval, we should use auxiliary gutta percha next to our master cone, and then we can cut it, and we should have a good condensation. And maybe because of that, we use the you know, the hydraulic condensation sometimes, besides of just saying single cone technique, because in the reality we just don't use one cone. Okay, maybe in like lower molar, maybe in the mesiobuccal or mesiolingual, maybe if I prepare it with a rotary, I could have a match between the canal and the gutta percha and just use one gutta percha. But in the like distal canal in lower mandible or palatal canal in maxillary molars, it's not true, and we need auxiliary gutta percha next to it. But we can cut and we can use the sealer as a pressure, so it condenses, and even it will go in the dentinal tubules. And if we irrigate it in a very good situation, we will have definitely good results.
Very good.
Yeah.
Okay, if you let me, I will actually share some details about the bioceramic sealers. We have talked about the actually lateral compaction technique with bioceramic sealer. We have a terminology which is passive lateral compaction, as Dr. Parissa and others said about the oval canals and the canals that are wide buccolingually or mesiodistally. We can use auxiliary gutta percha beside to the master cone. But in this situation, we don't need to use actually a spreader. We just put any extra gutta percha passively besides to the main gutta percha. And this technique is important. And the reason of this technique is to have a core of gutta percha for the future situation. We may need to retreat the root canal treatment for the tooth. And this core of gutta percha will help us to remove the actually gutta percha and sealer more easily, because as you know, we have some problem and issues about the retreatment of bioceramic sealer. But nowadays, because of changing the biomaterial and the base of the bioceramic sealer from MTA material to 3 calcium silicate base sealer, it is now more easy to remove bioceramic sealer from the root canal system. But there are some issues and problems, and we have many articles mentioned that there are actually problems to gaining patency when we want to retreat any root canal treatment that was obturated by bioceramic sealers. And the other issue that we have talked about the faster healing, we have faster healing because of bioceramic sealant. This is very important because of the bioactivity and biocompatibility of the sealer. We have faster healing of any lesion, and it is very important, and it will guide us and show us that our treatment is successful. If you agree,
we have a lot of Dr. Ali, sorry I interrupted you. I think retreatment in these cases is really important because you know, all of the companies claim that you know, these kinds of sealers are like a definitely successful treatment, that we don't need to retreat and everything is perfect. But we should have always in our mind, even, you know, all of us are endodontists, but we have a lot of dentists and a lot of, because of the, you know, material, that it's really easy and time saving. All of us should know that maybe even me as an endodontist, maybe I should, you know, retreat my case. I've done it.
Exactly.
I really say that I've done, I even retreated my own cases, because we never can say that we are 100% perfect, okay? And if I want to retreat it, what should I do? And you definitely said a really right thing. We have gutta percha as a core, and we can not easily, but we can retreat it because of the core material, because MTA is really hard to retreat. But in our mind, when we know that we have a kind of material like gutta percha, because as you all know that we don't have a solvent to retreat it, but we can retreat these kinds of bioceramic sealers with ultrasonic or lasers or even mechanical retreatment techniques. And it's really great that we know in our mind that we have an option that if in 100% we needed to retreat it, we can do it. And it's really good.
Exactly. We have actually some techniques to retreat these cases, and also you should consider that we have apical surgery, apical microsurgery is still as one of the choices and one of our weapons to deal with such cases. But there are some concerns about the retreatment challenges we have, and nowadays the contemporary endodontics, we don't have any solvent for bioceramic sealers yet. Maybe in the future we may have the bioceramic sealer that
we
may
should
have
think about
solvents.
it.
Yeah, we should think about it, and we hope that the material, actually the market of dentistry, will provide such bioceramic sealer. If you agree, I will go to share some actually contents about the bioceramic sealers, and then we will go about the discussion. And if you have any question and anything, you are free to ask or talk about. I have pinned actually a comment by one of the participant. Please just read the comment and think about it. We will discuss it at the end of the show, because I think it's an important question, but we have to analyze this question by different concepts, and we have to answer it clearly. And I think it's an important question that should everyone ask about it. Okay, let me share my cases if I can. Okay. Let me go back. Okay. This is the first actually phase of endo leadership. We are happy to have STEAM endodontists in our team, and as you know, we are developing, we are getting bigger and bigger every day, And this is a great chance for all of us that we can share our knowledges and our experiences together. And the Endo Leader Show is a great platform that will help all of us to share our knowledge and our experiences and our concepts about any field of endodontic treatment. So I want to see the difference between the two techniques. We have actually a ZOE-based sealer and resin-based sealer. But if you do any root canal treatment by only one gutta percha and the other actually root canal system was filled with the ZOE or resin-based sealer, it is not acceptable, because as all of us know, this is not an acceptable technique. But you just look at the lower picture and you will see in this case that we can use nowadays only one gutta percha and single coat technique by bioceramic sealer, because bioceramic sealer in such situation is used as obturating material. It is not to use fill the gaps between the gutta percha and the wall. It is used as actually obturating material, and this difference should be considered. Okay, how can we use bioceramic sealer in the root canal system? We have different types of using bioceramic sealer. Some suggest by actually the company, and also all the dentists and all the endodontists have shared their techniques, and we have different techniques to use bioceramic sealer. Just look at this video. You can see two different concepts. At the left teeth, as you see, we inject the bioceramic sealer by a needle. It is gauge 27 or 30, and then we will put the gutta percha into the root canal system. But in the right tooth, we use actually gutta percha as a carrier to put the bioceramic sealer into the root canal system. There is no difference, but some suggest too that we can use actually needle to inject the bioceramic sealer into the root canal system. As you see, it is it can be better because you can feel all the areas, all the radicular canals, all the actual root canal system. But when you use a gutta percha carrier base, you may have some voids in the root canal system, but depends on your actual technique and your skill. You can still use this technique properly if you use much amount of the bioceramic sealer in the root canal system. Okay, let's pass this. We have many articles about the indirect use of ultrasonic to push and to fill the root canal system by bioceramic sealer. In this technique, you just need to grab the gutta percha and then actually use your ultrasonic indirectly on your gutta percha. It will help the gutta percha by the textotropic characteristic feature that I talked about, and it will help you to better fill the root canal system completely by the calcium silicate base sealer or bioceramic sealer with this technique. Indirect ultrasonic has a very good compatible and very good technique to fill the root canal system hermetically. And when you see the different section of the tooth by obturating the root canal system by bioceramic sealer, you will see this cross section. As you see, the gutta percha role in this technique is to have a path for the future retreatment, and it will feel actually it will help us to guide to the apical area if we need any retreatment. There is an interesting study which was published on 27 March 2024, and it is a systematic review. Dr. Diana, Dr. Shahraman, Dr. Sabeti was the author of this article. And in this article, which is systematic review and meta-analysis, they showed that there is no difference in the clinical success when you use resin-based sealer and bioceramic sealer. So it is very important that we should say that, okay, bioceramic sealers are not better than resin-based sealer, but we can say that they are equal to resin-based sealer. And the important issue and the important point that Dr. Parisa has talked about, using bioceramic sealer will make your treatment easier because you just inject the bioceramic sealer into the root canal system, and then you fill it easily with the core of gutta percha. So I just want to show that we have different concepts and we have different techniques in using bioceramic sealer. We should consider that in the actually bio research, we are not eligible to use different technique because we should follow the main concept. But in technique, we can actually use our own concepts, and it is very important to consider this. This is one of the techniques that was suggested by Dr. Riccardo Tonini, and this technique was invented by him, how to use bioceramic sealer into root canal system. He suggested to use e-reflex tip to inject the bioceramic sealer into the root canal system. As you know, e-reflex tip has an end open, actually end tip, but yeah, but it is side vented, and it is very safe to inject the bioceramic sealer also in the apical area of the root canal system. There is no actually dangerous to push much amount of bioceramic sealer beyond the root canal system. And we can use, as you see in this video, you can easily inject the bioceramic sealer even at the apical third of the root canal system without the fear of extruding much amount of bioceramic sealer beyond the apical area. This is a very safe technique, and I really like this technique. You can replace any tip of any material, any bioceramic material, with the e-reflex tip, and then you can inject the bioceramic sealer into the root canal system by e-reflex tip. But if you see, we have a low amount of apical extrusion of bioceramic sealer, but there is no concern nowadays about the bioceramic sealer extrusion because they are biocompatible. But we should consider the anatomical areas and the areas that we are not allowed to extrude the bioceramic sealer. I really like this technique, and I just wanted to share this technique with you, and you will see the final result at the end of this video. And also there is another technique which was suggested by Dr. Alan Ali Nasser from America. I really like this technique because when you do minimally invasive access cavity, or when you do minimally invasive root canal treatment, when you want to cut, for example, two gutta percha from mesiobuccal and mesiolingual, the heat may actually put you take your gutta percha out of your root canal system. And when you take a final radiograph, you will see that your obturation is under. And if you want to actually manage such situation, there is a good suggestion by Dr. Alan Ali Nasser. Let's see his technique. He used reverse direction of the rotary files to push the bioceramic sealer into the root canal system. As you see, he just cut the gutta percha at the point of the orifice level, but not completely cut the gutta percha completely. And then, as you see, you will have the gutta percha with the type of cutting at the level of orifice. And then let's see what he do. Did you see? When he put the gutta percha in the root canal, then he rotates the coronal part of the gutta percha, and it will cut at the level that you have cut it actually completely. This is a very good technique. There is no need to use heat or to cut the gutta percha at the level of orifice. This is a very safe technique, and there is no concern of taking actually gutta percha out of the root canal system when you want to cut the gutta percha at the root canal at the orifice level. This is a very good technique. I really like this technique. And this is another gutta percha in the mesiobuccal canal.
Dear Dr. Ali, can you shift a little bit lower so he see?
Yeah. Do you have it completely?
Yes.
Just look at.
Now it's better.
It's better. Okay. I thought it was good. Just look. He put the gutta percha in the root canal system, and then he rotates the coronal part of the gutta percha because of the cutting edge at the level of orifice. There is no need to use heat to actually cut the gutta percha at the orifice level. It gets cut by the rotating the coronal part of the gutta percha. It's a very good technique when you want to use such a minimally invasive access cavity, and when you want to fill the root canal system by the bioceramic sealer and the gutta percha. Thanks for your attention. This was the actually content that I wanted to share with you. I think these techniques are very important to be considered, but if you want to go further and go deeper into the area of the bioceramic sealer, you should actually read many papers and articles that we have in the literature, or you can go for any videos that have been shared by many endodontists around the world. Okay, let me rotate my camera. Okay,
Thank you, Dr.
Thanks, Dr. Ali. They were very useful techniques for the bioceramic sealer obturation.
Thanks for sharing your content. I was enjoying your cases. If you have any question, we can go for the question. If you let me, I will ask some question, and at the end, if you have any other question, you can ask and we will discuss. I just wanted to ask you, when you use bioceramic sealers in your daily practice, do you use bioceramic sealer for every cases? And can you tell me the percentage of the cases that you are obturating with bioceramic sealers? Dr. Paisa, you start, please. And then we will go with other.
You know, it definitely depends on the case, I really believe. Like when I have maybe tooth number 8, I won't, and I know that it's really nearby the inferior canal, I won't use bioceramic sealer because maybe I will extrude it and I don't want to, think about what's going on. But if I have a case that's routinely done, I will use bioceramic sealer. And even I know, because we discussed a case that you was telling that in open apex we shouldn't use bioceramic sealer, but I remember that I've written an article that in open apex we can use bioceramic sealer because of the fluid that comes around and the biocompatible contains that are in the sealer. Besides of resin sealers, we're comparing these two kinds of sealers with each other. I know it's good. Even in open apex, we can use it. But I mean, in cases that it's a little bit risky, maybe I will be a little bit conscious about it. But if I, even Ali Nasser, he has two techniques. I don't know that, have you heard about it? He said that we have basic technique, we have advanced technique. Like in basic techniques, he maybe will insert the sealer not with the injectable syringe, you know what I mean? He told that I can use it and I can spread it on just a pad, and I can put the gutta percha, the master apical cone. I will just a little bit sealer with it and put it in the canal, not injecting the syringe. But in the advanced technique, as we use it routinely, we will notice the pressure that we should use in the cases. And after a time that we routinely use it, it will make difference. Like maybe in the first case that I'm using, I won't use it in a lot of amount, or I won't use it like you said. You told me, that like 1/2 or 1/3 of the canal, you shouldn't insert the syringe more or beyond that. I really agree with this concept, because if we put the injectable syringe beyond the amount of the canal, we will push a lot of sealer around the canal. But if we use it in tiny, miny amounts, we won't have that kind of concerns. And it's a good thing. And I think everything after that we try and experience some, things that we see, we will get how much and how we should use it in a very good amount. So we will have a good, prognosis in our treatment. Yeah. Then the answer of your question, if it's really risky, I won't use it. But if I'm aware of everything about the structures, and even like, I've read an article that bioceramic sealers are much better used in multiple session, not just one session. If I have a patient and I want to complete my treatment in just one session, maybe resin-based sealers are better, because we have a predictable prognosis and everything will be great. But in patients that we want to use medicaments and we want to change the pH of the, the structure around the root, maybe using bioceramic sealers is a good option, because we can put it in multiple sessions and see the patient and see the result. And in these cases, I really rely on bioceramic sealers. And, in my daily practice, in my dental, in my private office, I have a lot of cases with like abscess or like inflammation tissues that are around the roots, or like lesions that I want to see healing. I really use the bioceramic sealers and I'm satisfied with the results. But not just bioceramic, I as well use resin-based sealers in my daily routine, maybe even 50%, not just I haven't shifted. But when I want to be easy and everything is good, I use bioceramic sealers. And sometimes in cases that I'm trying to challenge myself and I want to see what's happening to my patient, and in the next session I want to see maybe the sinus tract is resolved, or if the abscess is getting smaller, I will do multiple session treatment with bioceramic sealer, And it's, I think it really depends on the experience of the, the clinician. I'm trying to do the shift from from resin-based to, bioceramic. But I know that it needs time, because I should have a concept for my own. Because I know a lot of people that have shifted and do a lot of cases just with bioceramic sealers, but I'm not that professional in that cases, and I need time. I'm maybe answer the question.
Very good. Okay, Dr. Mona, please go on, but please consider the time and please answer my question as short as possible. Thank you. Because we want to discuss many actually issues. There are many issues left.
Yes, actually, as I told you before, I did not shift to bioceramic totally. It's maybe 50-50 as Dr. Parisa said. So in cases like when I have C-shaped canals, I prefer to the core of the obturation to be gutta perca. So I use AH plus sealer with warm vertical technique. But in cases like if I have narrow calcified canals, and I will use bioceramic sealers. And I want to mention other thing, as Dr. Ahmed mentioned, I noticed in my patients the post-operative pain with bioceramic sealers was reduced for me. There was a study, systematic study as well, about this, that bioceramic sealers reduce the post-operative pain in the first
Yeah,
24
exactly.
hours. Yeah.
Exactly.
Yeah, it was a very interesting article, and about
Yeah.
the amount of the sealer. We are not we are not concerned and
Yes.
fearful as resin-based sealers. It's a very good point that we should
Because it
consider.
has it has antimicrobial activity, and also it has biocompatibility. That's the thing. Dr. Ali, I want to ask one question about this bioceramic. I want you to keep it in mind. What should be the irrigation protocol? What should be the, because these sealers are hydraulic. It sets in
Got it.
humid conditions. What should be the irrigation protocol?
Yeah,
I want.
okay, this will be the next question, but I prefer to Dr. Ahmad tell us
You know, Dr.
my question and
Ali,
answer.
you are teasing us. You know, every question that we ask, you say, "Okay, this is my next question." I really,
this is my
you can't
trick.
do this with us.
This is my
I
trick
say,
to buy
what's
time to think about
the
your
effect
question.
of pain?
Yeah,
You
it's about
say,
the timing. Yeah, I know. You're managing the time. Yeah.
Yeah, to buy the time to think about the question and also for the other question. But be sure I will answer all the question you ask me.
Okay. So what was the question again? Because I couldn't.
Yeah, the question was the actually indication and how how often do you use bioceramic sealer in your daily practice? If you can tell us the percentage of your cases, if it's possible.
Okay, I would go for 80% because I prefer to use bioceramic in necrotic cases and retreatment cases. Being a specialist, I don't get easy cases. I don't get the straightforward cases. Most of my cases are retreatment or compromised cases. Let me show you this one. This case is typical cases that I get every day. So when I treat such cases, I don't treat it on a single visit. I will treat it in a multiple visit, as Dr. Barcia mentioned. And this case had two missing canals, which was very calcified with a large periapical lesion. And we had a trouble with the obturation in the distal canal also. One of my students tried to retreat this case, and he did a perforation in the bifurcation area. So when I treat such a case, I prefer a bioceramic with resin that have a high toxicity that would injure the surrounding tissue. Here, after 3 visits of calcium hydroxide application, I rinsed the canals carefully with saline as a final rinse. I always prefer to use saline, and obturated the canals with single cone and bioceramic sealer. This one was treated with En-ROUTE, which the one I mentioned. It was the latest product that came to my hands, and we can see. Let me take this one. Zoom. If we can notice, there is a bone deposition all around. We have like a bone everywhere, but the bone is not as much as condensed as the originally located bone. But yet it's only 1 month follow up, and we have such a result. only 1 month. Back in my old days, when I used resin sealer, it would take like 6 months to see such bone healing. So I would go for 80% of my cases because they are not easy cases. They are not straightforward cases. Most of the cases are treatment cases and they are hard. If I'm going for a single visit endodontic treatment, I would go for a resin sealer which is modified by 14% MTA.
Very good. Thanks for sharing your concept. As you mentioned, you have the experience of using en-route sealer. As you know, we are here on the behalf of ENP company, which produces en-route sealers and en-route putty. I have read about the en-route, and I want to actually introduce us more details about the en-route. I have read about the en-route sealer, which the company claims that it can tolerate high temperature. Other sealers, when you use the high temperature, when you use heat, the properties of the sealer will change. But the en-route sealer will claim that, and there is also a amazing clip.
It's not evidence-based, Dr. Ali. It's not. We don't have enough research that would support this opinion. So I don't trust companies that much when they say that they have the bioceramics that is heat stable. I can see it with my eyes when I use microscope that there is a change in the consistency. I feel like the water has evaporated and I have only powder. So I wouldn't go for a warm vertical compaction with a bioceramic, even if they claim that.
Yeah, because we need articles that have tested these. But the companies actually have their own R&D research, and they may claim many things. But we should consider that we have to test all the claims and all the details that any company and product will tell us. But this will be a good news about the future of the bioceramic sealers, which can tolerate high temperature, and it is very good when we want to use them with actually warm vertical compaction. But you should consider that there is no necessity to use bioceramic sealer with warm vertical compaction technique, because the main concept of using bioceramic sealer and single contact aperture is to actually getting obturation technique easier. There is no need to do such actually technique with bioceramic sealer, but if they can tolerate high temperature, it can be better.
News.
Yeah,
yes,
it will be better.
It will be good news because we will be really relieved.
Exactly. Okay.
We don't have any time.
No.
Because you haven't answered the question about the wettability of the canal.
Yeah. About
the irrigation protocol. Yeah.
My irrigation protocol. There is no difference in my irrigation protocol when I want to use bioceramic sealers, and I will do the same. I will actually remove the smear layer with EDTA and hypochlorite. But when I want to dry the root canal system, I will not dry it completely. I actually use just some paper points to lower the wetness and the amount of the water or any solution in the root canal system, but I will not dry it completely. But many articles and actually many companies claim that the actually amount of any wet in the dentin tubule is enough for the final setting of the bioceramic sealer. But I prefer to leave some wetness in the root canal system, and I will not dry it completely. I prefer to not completely dry the root canal system if I want to use bioceramic sealers. But for the resin-based sealers, I will dry it completely.
And yes. Sorry, doctor, to complete you, I've read an article that it has 3 situations. It says that we can have like moisturized canals, and we can use paper point or super dry, And
super dry is not
it tells that it shouldn't be super dry,
exactly.
And just paper point, and maybe a little bit of moisture is good.
Exactly.
In even using bioceramic.
That's the point, but depends on I think the type of the sealer because every sealer has their own setting properties. Some may need lower amount of moisture, but some may need higher amount of moisture. We should actually follow any suggestion by the company and by any product. But if you have any articles that has been published about any specific sealer, okay, we will go for the publication, we will go for the articles. But in actually the situation that we are now standing, there is a lack of evidence, but this does not mean that we are not able to use our own concept or following the actually the company details.
Yes,
Okay,
to complete your answers, because bioceramic sealers interact with the environment that they are placed in, sometimes the final irrigation protocol is very important. As I read the article about single syringe bioceramic sealers, the one that comes with single syringe, we need to remove the smear layer. So we need to remove the smear layer, and they need moisture to set and develop their properties. So at that situation, we can use EDTA. But as you said, it depends on the brands and composition of the sealers. Some sealers, they don't need EDTA.
Okay, Dr. Ahmad, what is your concept about the dryness of the root canal system?
Okay, EDTA is a must. First time I usually do remove the smear layer. I feel terrible if I didn't do that. Then I would use saline as a final rinse. I wouldn't leave any remnant of the EDTA in the canal. I use only one paper point of a taper 04 to take the most of the moisture. I don't want the canals to be dry. I want it to be moistured. So only one paper point is enough. It will take the majority of the fluid. Then I start to inject the bioceramic, and one single cone would be placed slowly and gently. Is enough to see the lateral canals and everything filled. Please let me show you only one more case, if our time would allow us.
Yeah, thank you.
Yes, this one is treated with the technique we just mentioned, and I can see in the apical part only after removing the smear layer and pushing gently with a single cone in each canal, I have this lateral canal filled with bioceramic. So we don't have to do that strict techniques that would cost time. It's very easy and simple. If I remember back in the old days, to get the same effect, I would do a strict root canal chelating agent and sodium hypochlorite. Then I would rinse with saline, then chloroxidine, and do warm vertical compaction to have the same lateral canal filled. So it doesn't need so much complications when we mention this technique about compaction. It's just hydraulic compaction. If the canal is empty and there is a minimal amount of moisture that would guide my sealer to the lateral spaces, I would do the obturation simply with a single cone.
Very good. Okay, let's answer to the question that the participant asked us. One ask a question about the long-term studies that we need about the bioceramic sealer. As let me answer this question, and I'll ask you to answer the question. As I showed you, there is a systematic review about the bioceramic sealer, and nowadays that we can claim that the success rate between bioceramic sealers and the resin-based sealers are the same. We are not saying that the bioceramic sealers are the magic, as the question I have pinned. We don't say that this is a magic, but we should consider it as one of the techniques and one of the actual innovations that we have in the field of endodontics, and we can use it safely, properly in any situations we have. For example, if I have a distal access case and I don't have enough access to the root canal system, I can easily obturate the root canal system with bioceramic sealer without any concern of the long-term success rate of the root canal system. If I want to use lateral compaction or warm vertical compaction, I may
really
have some voids, and that may hinder or actually lower the success rate of my treatment. But I can easily have a good obturation at such hard or challenging cases. It was said that in the past that we were not able to, for example, actually manage strip perforation with bioceramic sealers. But today we can claim that we can manage a strip perforation that is very challenging to be managed directly or in an orthograde manner by actually endodontic treatment, but you can manage it easily by bioceramic sealers. They're not magic, but we can say that we can shift to bioceramic sealer if we want to have easier treatment, if we have challenges that we cannot handle or manage by the previous obturation techniques.
Please let me add one point, Dr. Ali, if you let me.
Yeah, sure.
About the flowability, you were like afraid that the bioceramic, because of its high flowability, would injure the periapical tissue. But I mentioned earlier that it is less toxic than resin, so I'm not scared that much if it goes beyond the apex, and I can make use of the flowability. Like this case, we had a broken file at the apical third of the curved part. This part wouldn't be treatable. I couldn't bypass the file. I couldn't find a way to retrieve it because it's been in the apex. But I managed with the use of EDTA and the salines in bioceramic manual agitation to push the bioceramic around the broken file. Here is a follow-up, like 2 months follow-up, and everything is going great. The patient had nothing. So the flowability of bioceramic is one of the most important points that we should mention. Resin sealer wouldn't help me in such case.
Exactly.
Yes, yes, it's not the magic, but it can help us with many cases we couldn't do back in the past with a simple endodontic treatment.
Exactly. That today we don't have any concerns about the sealer extrusion if we don't have any actually anatomical or critical areas. We can say that the body can tolerate the amount of the sealer that has been extruded from the apical area or any lateral canals or any passage to the actually periodontium.
You know, eventually body can resorb some of the pushed bioceramic. Even the bioceramic can be resorbed by the body, but it's not the same amount of resin. Most of my follow-up cases, I find some white ashes or some radio-opaque material beyond the apex, but it's not fully resorbed as resin. Resin would, if you let me, this case was a resin sealer. This case, after treatment, we had this large amount of resin sealer. After 3 years follow-up, everything was great. It was totally resorbed. But when I come to the bioceramic, if we can see this case, this one we had after the retreatment in the distal root some ashes of bioceramic material. Here, after 14 months follow-up, I still have the same. Maybe the shape is a little less, but still we have the shape of a radio-opaque material. It wasn't fully resorbed, but the patient is completely asymptomatic. They have nothing, and everything was going great. So I'm not scared of the buff that would happen from bioceramic sealer.
Yeah, exactly. But we should consider that there is a study about the MTA extrusion, and when we have a big mass of MTA in the body, for example, in the bone, we still have some concerns because the body cannot completely resolve or tolerate those mass amount of the extrusion of the sealer. We should keep it as small as possible, but if it gets higher, we can be hopeful that the bioceramic sealer can act better and more biocompatible than resin-based sealers. But about the anatomical areas and about the amount of the sealer, we should still have our own caution. Okay. If you have any other question, we can go. If you have anything about the bioceramic. I think we have talked about the main important issues of bioceramic sealer. I'm reading about the questions and also about the jokes that the participants have made.
Uh,
Okay.
Please
let me add
let
you
me add
some.
one more. Please, Dr. Mana, go ahead.
Let me add something. Here, our colleague has written the sealer is the least important factor
I
in the root canal
was going
treatment.
to reply to this too.
One Yes, I want to mention that one of the key important thing that for successful root canal treatment is to prevent ingress of bacteria toxins inside the root canal system and periapical tissues. To obtain this, we need to get proper tight coronal and apical seal. With bioceramics, because of their superior properties, they create chemical tight bond with dentinal wall, so there will be no gap and void between the sealers and dentin. That's the issue that makes it a tight seal. So this is very important for ingress of bacteria, to be honest, to have a long-term successful outcome.
Yes.
Exactly.
So, I was going to reply to the same comment we had from our colleague when he said the sealer isn't the least important factor. I totally disagree with him because back in the old days when we used zinc oxygenol, me myself, I had many cases which look perfect on the X-ray, but due to the dissolution of the sealer, it failed. Also, there is a paper, there is an article that was discussing the sealing ability against Enterococcus faecalis, and if you want to read this article, I can share it with him. The article gives a very interesting result about single cone bioceramic, which is comparable to collateral compaction or resin sealer. So the sealer does matter because even with a timber root canal sealer, which is calcium hydroxide, we managed to kill the bacteria and disinfect root canal and induce a faster healing. But with a straight resin sealer, we don't have all these benefits. We have only the sealing ability.
Yes,
Exactly.
I do
Okay.
agree.
Can I add one sentence?
Yeah, sure.
We are not magicians, and we really agree that we are not doing magic. And I'm not a magician, and none of us are magicians. But we really can't close our eyes and say we are blind, and we don't see a lot of good and successful treatments. It's bad, you know. It has a lot of benefits. We should have it on mind and we should notice it. And in the cases that are really useful and we should use it and its benefit, we use it. We're not magicians, but we are not blind people. We see, we notice everything, and we'll do the best based on the condition of our patient and on the situation of the tooth. And definitely, we don't want to harm our patient. I think it's
Exactly.
really important.
I think there's a great quotation, and I really liked it. It said that do not be the first one and the last one that using a technology. And we can say that the bioceramic sealer is standing at the point that we can go for it. If you wait too long for bioceramic sealer, you will be the last one that using the bioceramic sealer, and you may don't have the chance of using the actually positive impact of the bioceramic sealer. And the bioceramic sealer has passed the great road, and as we have talked about, we can say that we have enough articles to talk about the bioceramic sealers, and we have growing evidences about the bioceramic sealer. We are not the first one that we are using the bioceramic sealer. We are standing at the point that the bioceramic sealer has growing evidences. We have to wait for the future articles and papers, but I think bioceramic sealer can be the future of the root canal system. I remember when I was resident, I was at my residency program, I thought the bioceramic sealer can have the actually same destination like the sealer that has been ruled out by the market. It was Resilon. I thought that the actually future of bioceramic sealer can be like Resilon, but when I waited and I saw the past and the articles about the bioceramic sealer, my mind had changed, and today I am standing at the point that I can say that the bioceramic sealer can have their own role in the daily practice of endodontics.
Definitely, it will have a very bright future.
Yeah, and we should consider that we don't actually have a dark and white side in the science.
Yes,
We have
that's
gray
true.
scale.
Yeah.
We are living in a gray scale in the science, and everyone has their own concept, and we cannot say that I'm right, you're wrong. Every of us have their own right and their own beliefs, but we should follow the evidences and talk with evidences as much as possible.
That's true.
Very good. Dr. Ahmad, for the last actually part of the show, because the ENP and the En-ROOT is the sponsor of this show, can you tell us your experience about the En-ROOT sealer, about the features, about the experiences, and how you use En-ROOT sealer in your cases that you have shared with us? We are all ears.
Okay. As I told you, I have been using bioceramic for like 5 years, and let's say it's very hard for someone to switch from one product to another. It's not easy for me to leave the product I trust and go to another one, especially in the bioceramic, because of the flowability and the mechanical properties. They totally different from one company to another. When I met them first time, I met them in EDIC Dubai, and I tested it. Yeah, the consistency was very good. The flowability was great. I had only concern about the setting time and solution, and later on I found it has 2 hours for the primary setting and like 24 to 48 hours for the final setting. So I was relieved. I said, why not? Let's try. It's much cheaper than the one I already used because it was a European product. I have been using for like almost 1 year En-ROOT from ENP, and I can see it has the same thing I mentioned to each other product for bioceramic: less post-operative pain, great flowability, good healing, as we saw 2 or 3 cases in only 1 month follow-up. I have healing, I have bone regeneration. It doesn't dilute. This is the most important thing. When I bought it in a strip perforation, it doesn't wash out. It doesn't disappear from the X-ray, or I have a complication after. So it is comparable to any other product I have used. And it doesn't set, this is the most important thing for the Egyptian market, it doesn't set if it didn't meet humidity. So if you keep it in the self-seal back carefully, it wouldn't set. It only set when you inject it in the canal, because this is the main concern when you switch to a much cheaper bioceramic from Chinese manufacturers. They would think that they will lose the syringe after 1 or 2 cases. No, I've been using it for months, and it is very good. It doesn't set unless you inject it in the canal. So I do like the product. I have many cases that I shared on my Facebook, and I will share more in the next few months of 4 months and 6 months follow-up for cases. If someone is interested to see the result, they can follow me.
Dr. Ahmad, yeah. Sorry, can I just ask a secret question?
Yes.
If you want to answer, you can answer. in like one syringe of en-route, do you use it for how many patients? Because I think about like cost efficiency and you know, the the subject of how you know, the cost and how is it efficient for a patient. I think it's a really important thing. If you want, can you share with us?
Yes, you know, the same question is asked to me here in Egypt many times. I don't count. No one counts how many cases, but I can tell.
You know, not
Yes,
average.
yes, I would give an average of 15 to 20 cases by syringe if it is as I said regular canals. But if you have wide canals, you will waste the majority. I just finished one syringe in like 6 or 7 cases this week because they had wide and open abysses. And they had retreatment cases that was originally prepared to a massive sizes. So it is about the technique, it's about the experience, it's about the quality and the how you inject into the canal. If you inject to the full length of the middle third, it's not an easy question to answer. It's like the question, how many cases should I prepare with my files? No one count. No one would. It's not easy to count.
Yeah, but it's not as a cost benefit as resin-based sealer as we have experienced.
Resin is much cheaper.
Yeah,
Yes, resin sealer are much is cheaper, but I think that if my cases wouldn't suffer from postoperative pain, if they will have a faster healing that will make me go for the prosthetic part faster, it is worth every penny I would pay for it.
exactly.
So I know it's
Definitely
expensive.
it will come back to you.
Yes, it will come back with good results.
Exactly. The nightmare is when you inject the bioceramic sealer in the root canal system and you see the bleeding is coming out of the canal. This is a nightmare because you have to completely wash out all the sealer in the root canal system. And I have the experience of that.
Exactly.
It happens. The money is coming out of the root canal system.
Yes, it happens sometimes, but I don't see it that way. I thank God I saw it with my eyes, and it was the proper time to remove the obturation material before a problem would happen. So shit happens. Yes, it happens every day. But is it a bad thing? I thank God that he warned me before I would go on as it is a perfect case. Then I would find out that my sealer is washed away.
Exactly. You always see the good point of every bad situation, and it is very good.
Yes.
I like your attitude towards the situation and problems. Very good. That's a good point. Very good. I think we are out of the time. And if you have any question, if you have any final actually quotation, please go on, or we will finish the session. I want to thank you. Thank you all for actually participating and accepting our invitation. It was a great honor for me. I think the discussion was very good, and I was very excited, and I didn't feel tired during the show because every step and every time of the discussion was very interesting and was very informative, and we get a great insight into the world of the bioceramic sealer, and we have changed our knowledge and attitude, and I hope it was useful for the participant on all the audiences in the show. We hope that we can see you in the future programs. As you know, the Endo Leaders Show team is gathered, and we are not finished yet, and we will have big projects, big programs in the near future. We are looking forward to it.
Yeah, it was a pleasure.
Thank you.
Thank you, Dr. Ali. Thank you, everyone. It was a really great show.
And even I saw that we answered a lot of questions that they are commenting right now. We discussed all of the questions.
Yeah.
Isak from
Thank you, guys.
en route
I
and
had a good time.
EMP is here. I will
Yes.
actually thank
Yeah,
her,
yeah.
but I have
Yeah.
to say we have to finish the show.
Goodbye.
Goodbye.
Okay.
Goodbye,
Thank
everyone.
you. Thank
Thank
you.
you. Thank
Bye.
you.
Bye.
Have a good
Bye.
night.